Welcome to tests of secondary hemostasis. In this video, we discuss the activated partial thromboplastin time, or aPTT. We have the following take-home points. The aPTT assesses the intrinsic and common coagulation pathways. The normal aPTT range varies across labs. An isolated prolonged aPTT with bleeding indicates a deficiency or inhibitor of factors 8, 9, or 11. To begin, let's review the intrinsic or contact activation pathway. We start with a contact-dependent factor 12, which, in the presence of high molecular weight kininogen and percallicrine, is activated to factor 12A. 12A, in the presence of calcium, activates factor 11 to factor 11A. 11A activates factor 9 to 9A. 9A has as its cofactor 8A, which helps factor 9A activate factor 10 to activated factor 10. Activated factor 10 has as its cofactor factor 5A, which works to activate prothrombin factor 2 to thrombin. Thrombin then cleaves fibrinogen to fibrin, and fibrin monomers combine to make fibrin strands, which are ultimately cross-linked by factor 13A to make a strong fibrin clot. The pathway from factor 12 activation to factor 8 is historically known as the intrinsic pathway. Deficiencies or inhibitors of intrinsic pathway factors will cause an isolated prolonged aPTT. The common pathway factors are factors 10, 5, prothrombin, and fibrinogen. A deficiency or inhibitor of one or more of these factors will prolong both the PT and aPTT. Let's move on to discuss the activated partial thromboplastin time. The aPTT measures the time to a fibrin clot in seconds. The test is performed by taking citrated blood and adding calcium, phospholipids, and kaolin, which activates the contact-dependent factor 12. Thus, the aPTT assesses the intrinsic and common pathways of coagulation. There is no standardization of the aPTT test across different reagents or instrument systems. Therefore, aPTT values from different labs cannot be compared directly. Each lab establishes the therapeutic range for heparin monitoring by determining the aPTT range that corresponds to 0.3 to 0.7 anti-factor 10A units per milliliters. The aPTT can be used to evaluate unexplained bleeding, diagnose disseminated intravascular coagulation, monitor unfractionated heparin therapy, and monitor parenteral direct thrombin inhibitor therapy. Causes of a prolonged aPTT include anticoagulants like unfractionated heparin, direct thrombin inhibitors, and factor 10A inhibitors. Also supratherapeutic warfarin. Severe or chronic liver disease due to decreased production of anticoagulant factors will also prolong the aPTT, and so will disseminated intravascular coagulation due to coagulation factor consumption. Von Willebrand disease can be associated with a prolonged aPTT in patients with type 2N or 3 disease in which factor 8 activity is significantly decreased. A prolonged PTT can also be seen in congenital or acquired deficiencies of intrinsic or common pathway factors. Patients with unexplained isolated prolonged aPTT and bleeding will have an acquired or congenital deficiency of factors 8, 9, or 11. In a patient with a history of thrombosis, a prolonged aPTT may indicate the presence of a lupus anticoagulant. Finally, polycythemia, especially when the hematocrit is greater than 55%, can cause a falsely prolonged aPTT due to excess citrate relative to plasma in the collection tube. In summary, the aPTT assesses the intrinsic and common coagulation pathways. The normal aPTT range varies across labs. An isolated prolonged aPTT with bleeding indicates a deficiency or inhibitor of factors 8, 9, or 11. This ends our video on tests of secondary hemostasis, the activated partial thromboplastin time.